Thank you. My name is Peter Fail. I'm the head of the structural heart program here at Cardiovascular Institute of the South. I want to thank Dr. Walker for inviting me for this presentation. It's a 30,000-foot view of device landscape for heart failure. These are my disclosures. I will be discussing some off-label and investigational devices for this program. So heart failure really has been a major issue for us over the past decade. Approximately 6 million people enter the health system each year with about 400,000 new cases, and unfortunately about 1 million hospitalizations a year. And the sad news is, despite all of our advances, we really have not changed this overall admission rate over the past decade. When we look at sort of the hospitalizations for heart failure, we can see that we wind up having patients have a chronic decline where they have multiple hospitalizations throughout their course till they finally succumb at the end of their lifetime. When we actually divide this out, we can see that there's really a whole scenario of things that we can do. So the early stages of heart failure, we obviously have medical therapy with diuretics and ACE, ARBs, beta blockers, mineralocorticoids, the ARNIs, and pressure sensors. And then as we move into the medical stages, we start with the CRT and the ICDs. And then obviously the late stages are transplant as well as hospice. But then we have this whole area here, which unfortunately can be very, very long in its time frame. And we have a whole host of things that potentially are available to this. Those include TAVR, mitral valve intervention, whether it's with replacement or a mitral clip, a tricuspid intervention, which is really in its early stages and probably beyond the scope of this talk, but then also right atrial, left atrial shunts, left ventricular modification, and even left ventricular reconstruction, all we will talk a little bit about today. So let's start off with TAVR. And obviously, you know, when we look at aortic stenosis, TAVR has been really the darling of the structural heart arena over the past a decade or so. And we know that as we move forward for aortic stenosis, we see that the vast majority of patients present with heart failure, although there are those patients that present with angina and syncope. I wanted to bring these trials up. This is the self-expanding style for the Medtronic valve that we've basically covered all gamuts of those people who are intraoperatively high risk, intermediate, low risk, and are currently in some asymptomatic trials. And this has also been presented in the balloon expandable or the SAPIEN with the same scenario of a cohort of patients. What's interesting, however, is that most recently in March of 2019, the low-risk trials got presented both for the ACC, both for the self-expanding and for the balloon expandable. And I just wanted to bring this up to show you not only the rehospitalizations, but also the rehospitalizations for heart failure, remembering that heart failure really is one of the driving forces that these patients seek treatment for. When we look at the assessment, the functional assessment improvement, but also improved when you can see that at 1 year, a very few people had class 3, class 2, or even class 4 heart failure. Even the vast majority of those patients after TAVR wound up having class 1 or better. And then the Kansas City questionnaire showed improved heart failure or feeling levels of heart failure. If we look at the right-hand corner here, we can see that the vast majority of these people were at least class 1 or class 2. Now, what's interesting about this is that over the next decade, we're literally going to see the incidence of heart failure double. And what that means from a TAVR standpoint is that there's going to be an enormous number of TAVRs being preceded between 2018 and 2025, approximately 2.5, and then possibly by 2025, 75% of all aortic stenosis will be treated with TAVR. So switching gears just a little bit, let's talk a little bit about mitral regurgitation, which is also a driving force for heart failure. And there's two major problems, the degenerative and the functional, as far as regurgitation. And what that to bring that is a sick valve versus a sick heart. And as we look at the left-hand side, it's the valve that really becomes the problem. We have either cords or a problem, or the valve itself is degenerated. On the right-hand side, the sick heart basically is as an evolution of dilatation of the annulus and or being pulled down with increased tethering creates the dilatation. The valve in itself is normal. When we look at the prevalence, however, the prevalence really dwarfs what we see as far as aortic stenosis. We see mitral valve disease really is a predominant player in all valve disease, with a vast majority of patients having some sort of mitral valve disease in of itself. Now, this is a slide from Dave Adams, and this is basically showing different forms of degenerative mitral regurgitation. And it really is a different pathology for each patient, but it has the same basic premise that it's degenerative. When we actually look, however, as far as what is seen in the everyday occurrence, it really is very minor compared to those patients with functional mitral regurgitation, which really is the vast majority of those patients that we see with heart failure. Now, unfortunately, heart failure begets heart failure. And as we look at the patients, those patients with heart failure, we can go on preserved ejection fraction. We're going to talk a little bit about this later on in the presentation. But really, this group of patients are the ones that we see a lot with reduced ejection fractions, less than 50%, class 2, class 3, class 4 heart failure, with a vast majority of those patients, somewhere in the neighborhood of approximately 40%, having at least moderate to severe regurgitation. And really, 1 in 5 of those patients today with heart failure have some level of regurgitation. As I said before, is heart failure begets heart failure, and regurgitation begets regurgitation. As we can see, increasing mitral regurgitation causes increased load and stress, which causes increased muscle damage, loss of left ventricular function, dilatation of the LV, worsening mitral regurgitation, and it's a vicious circle that winds up with a mortality of greater than 50% at 1 year. And we can see these lines here that they all sort of, even the moderate mitral regurgitation, all portends a bad prognosis. Unfortunately, our treatment therapies are actually very limited. When we look at surgical, for instance, the vast majority of these patients, less than 20% basically get treated with some surgical intervention. And I'll show you a little bit why that is. But the vast majority of patients, truly a conservative management, which unfortunately doesn't seem to work very well. The COAPT study was a study that looked at using the MitraClip, and the MitraClip had been previously approved for degenerative mitral regurgitation in prohibitive risk patients, and this was now looking at those with functional MR. This study took 305 patients in both groups in a 1-to-1 randomization. In those patients who were already on guideline-directed medical therapy, they were reviewed by a committee to confirm that they had met all the criteria, and then they were randomized to either MitraClip or the standard of care. When we looked at this was an amazing trial, not only in its able for rehospitalizations, but moving out to 3 years, the lines continue to diverge with the number of people that we need to treat as 3 patients, all hospitalizations for heart failure at the end of 36 months, and the treated with the MitraClip, and the curves continue to diverge. All-cause mortality, and this was really a little bit of a game changer, although the curves may start to be coming together a little bit. The number of needed to treat was 8 patients at the end of 3 years, still in favor of MitraClip and guideline-directed medical therapy. And then mortality, again, showed benefit of the MitraClip, with the number needed to treat just under 4 of those going under clip with guideline-directed medical therapy for those patients who have functional mitral regurgitation. If you look at this whisker plot, literally every category benefited from MitraClip, whether they were young, they were old, they had CRT, they did not have CRT, they had previously high surgical, low surgical risk. Every one of these patients benefited from CLIP over a guideline-directed medical therapy alone in functional mitral regurgitation. Now, this is the landscape of mitral valve replacement, and this is going to be one of these series of moving forward is, are we going to repair or are we going to replace? We'll talk a little bit about this. This is a little bit out of the realm of this possibility of this lecture, but this is some of the numbers that are out there, just a partial list of what's going on in 2020. This is a young lady we did a couple of weeks ago for the new Alta valve, and this is basically placing a valve inside the left atrium on top of the annulus, providing repair of or replacement of the mitral valve. And this is going to be a war going on, whether we do a repair with a MitraClip or we do a replacement. And right now, the replacement therapy is still in its infancy, although this will clearly become competitive as we have a final approval of a device. Again, this is going to double over the next 20 years, where we're going to see an enormous number of patients presenting with more functional regurgitation, with a vast majority of having some level of at least mild to probably moderate disease. Now, when we talk about functional regurgitation, we talked about replacing the valve. We're actually looking at symptoms, and we're not going to the root cause. And obviously, the root cause is the heart itself. And so we see LV dysfunction, functional mitral regurgitation, volume overload. We then cause more LV dysfunction. We saw this previously, and this begets more MR. So as we look at this, is actually the scar, the increasing scar formation, and this is what's causing the tethering and the worsening of the MR. So one of the interesting things that we looked at is that the increase in volume. And so as we see that the increase in systolic volume worsens as we get with MR, as we've previously seen. As we looked at now, if we do a therapy, and this is a new therapy being studied right now called the Ancor Heart, and this is basically the core cinch. We actually put in an annuloplasty ring, if you will, in sort of the upper portion of the left ventricle to reduce the size. And just to give you sort of a cartoon look, looking down from the mitral valve, or looking up from the mitral valve, reducing the LV volume from this to this. And that, portends a decreased volume. When we looked at this is a young lady that was done several months ago at another institution, and you can see that there's a reduction after the device is cinched, if you will. Now, what's interesting is although the COAPT study had shown improvement of both heart failure admissions and mortality, if you look here, you can see that there's still, in the control group, the LV size, or the LV end systolic volume, was higher in the control group, and even in the treatment group was much higher than in the early phases of the core cinch trial. And we know that a big heart, it portends a bad prognosis. So being able to reduce the LV volume has some benefit. What about if we have an anterior scar? So this is a young lady that we had seen previously in our structural heart clinic who had a large anterior scar. So obviously fixing the posterior part of this lady's heart would not be of any value. And when we look at this scar here, there has to be other answers. Now, previously the surgical intervention was to go ahead and do a plication. This is Bailey's idea back in the early 50s. And then this was modified by both Cooley and Batista, and eventually Dorr, to try to basically do a surgical replication of removing the scar altogether. Now, if we take this and modify this slightly and do a sort of a hybrid approach, we use what's called the Revivent procedure, and where we're able to do a mini thoracotomy and we plicate, if you will, the scar itself by going from the anterior surface of the left ventricle and going to the interior surface of the scar on the right ventricle. We have no mediastenotomy. We have no left ventricular otomy. We no need to close the LV. We have no coronary bypass. We don't have to cross-clamp the aorta. So a very, very elegant solution to a pretty big surgery. The whole idea based on reducing wall stress. So if we can actually take this diameter, if you will, and reduce it to this diameter, reducing wall stress, and by Laplace's law, we should improve all LV performance. To give you an understanding, this is the young lady we had previously seen. This was a 71-year-old female referred to our clinic. She did have an anterior wall MI as seen by the CAT scan about 8 years earlier, underwent a PCI late, and did well originally, but developed 3 to 4 class symptoms when she was seen to us. She had undergone an ICD. She was turned down from orthostatic heart transplant, and LV therapy was offered to her. However, she felt because of her lifestyle, this would be severely limiting, and was really told at her last admission to get her affairs in order. This was her CT scan. As we've seen, a large scar in the anterior wall. What we did is we did the Revivent TC LV reduction, where we were able to put 4 anchors on the LV side into the RV side and reducing her LV volume. When we looked at her echo, this is her echo in the pre-op, a very bulbous looking LV with an ejection fraction of 28% and a left end diastolic dimension index of 118 milliliters per meter squared. At the end of the procedure, her EF improved to 46%. Her volumes reduced to 54.52 milliliters per meter squared with a 46.19% reduction. And this is really important based on the STITCH trial, which showed that if you were able to do in a subgroup analysis greater than 30% reduction, that there was improved in overall survival. Looking at her echo, you can see here the pre-echo, very bulbous looking, and then post-echo, almost a very normal looking LV. Now, switching gears just a little bit in preserved, as we talked earlier, there's a lot of faces preserved ejection fraction heart failure. And this is probably one of the things that we struggle with a lot. This is the young lady who comes to your clinic who complains of shortness of breath. And when you look at all of her studies, they're reasonably normal. There's nothing that really stands out in diastolic heart failure. And it almost becomes a diagnosis of exclusion. And the problem with it is not one single disease. When we look at it, we see the garden variety of heart failure, hypertension, diabetes, obesity, maybe some chronic kidney dysfunction. We have those people who have coronary artery disease but still have preserved ejection fraction, whether it's right heart failure, AFib with preserved EF, those patients with HOCM, high output failure, valvular heart disease, typically with more than one lesion, and then the rare causes of preserved ejection fraction heart failure. But all in all, it's not one single disease process, and therefore probably doesn't offer one disease fix. So the common thread, however, is increased left atrial pressure at exercise, at rest or with exercise. And this is something that we're currently studying. So the idea is that if we actually increase the left atrial pressure with exercise, can we put in a shunt? Can we do something that offloads the left atrium into the right atrium? This is actually the Corvina study, and this is basically an implant, a 19 millimeter OD with an 8 millimeter ASD, and in the animal explants shows complete endothelialization, but offering a complete shunt with a QPQS of about 1.2 to 1.3. Looking at the early feasibility study in reduced LAP HF1 trial, you can see that there was a reduction in left atrial pressures as we move forward with both exercise as well as rest. What was interesting, however, is that we saw 55% fewer heart failure admissions, 47% with heart failure events with increased diuresis, and 65 with IV diuresis. So all in all, these patients did markedly better at 12 months versus control. Because of that, there's been several ideas that have been forth. Different companies look at the same sort of a scenario of providing some level of a shunt across the board between the right and left atrium. I think heart failure remains a significant healthcare burden with multiple etiologies. The structural heart intervention offers multiple different procedures to address a lot of these issues. TAVR and TMVR with the MitraClip have really become mainstays in today's patient load. However, I think TMVR currently in its intervention will slowly take hold as we see more and more data come out. LV modification procedures are currently under investigation. We've seen some of those patients do incredibly well. Diastolic heart failure is becoming a predominant cause, and in the near future will really dominate those patients who come to the hospital with heart failure will have preserved ejection fraction. I think there are a significant number of new ideas in treating patients, and currently for those patients who have no options. Thank you for your attention.